المرحلة الأولى مع الدكتور أحمد عبد الله. اتفضل يا دكتور أحمد. أيوة.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. My dear professors, my dear colleagues, ladies and gentlemen. Let me introduce myself. My name is Dr. Ahmed Abdallah Abdel Qadir. I am an assistant lecturer of internal medicine and rheumatology at Ain Shams University Hospitals. It's my great pleasure, and I'm so happy to be with you today and to share our exciting case with all of you. We selected to entitle our case with this title, Flexion Deformity of the Elbow of a Young Man. And here we go. A conversation between two doctors about the flexion deformity. What do you think about flexion deformity of the elbow? Easy, arthritis for sure. Okay, we will see. Personal history. Our patient is a male, Mr. GGA, 17 years old. He was born and now lives in Giza, single student. He reported history of occasional alcohol intake, not regular intake, but occasional 1 or 2 or 3 times per week, and half a cup. Cigarette smoker also, from 2 to 5 cigarettes per day. No other special habits of medical importance. The complaint: elevated body temperature of 1 month duration. History of present illness. The condition started 1 month ago when the patient developed high-grade fever up to 40 degrees, more at night, associated with generalized arthritis, bony aches, unable to walk, vomiting, diarrhea, and puffy eyelids. He was admitted to Abbasiyah Fever Hospital from 5th to 21st of December 2019, diagnosed there as brucellosis and received antibiotic treatment without improvement. The patient then was presented to us at the outpatient clinic of our department, wheelchaired with difficulty to stand, high-grade fever, flexion deformity with severe pain and swelling of both elbows, severe back pain, and limitation of all active movements of elbows and hips. He also reported loss of 5 to 7 kilograms in 1 month age, had no history of lymph node enlargement, oral ulcer, food sensitivity, or butterfly. Examination, general examination. The abnormal finding here with pallor, blood pressure 140/80, with tachycardic pulse 110, regular average volume equal on both sides, respiratory rate 28 per minute, and temperature 40 degrees. Upper limb examination. There was flexion deformity of both elbows, severe tenderness on palpation, palpable periarticular swelling of both wrists and elbows, normal both hands. There was also limited all active and passive movement of both elbows. Lower limb. We found bilateral lower limb edema, pitting till anterior abdominal walls, non-tender. There was tenderness over both sacroiliac joint and the gluteal muscles, with limitation of all active and passive movements of both hip joints. And there is also limited lumbar spine flexion. To see the finding, we found it in our patient during the musculoskeletal examination. We will see that video, note the gait, and note the flexion deformity of the elbow, as we see here. Look at the gait, look at the flexion deformity of both elbows. Cardiac examination was normal. Chest examination was normal, except for bilateral diminished air entry on both lung bases. Abdomen, there was diffuse abdominal enlargement with bilateral shifting dullness, but no tenderness, and there was dull tropes area. Laboratory results, all of the chemistry were normal except for severe hypoalbuminemia 1.9 gram per dc, and the following readings were after correction by human albumin injection. As regards the CBC, we found that all lines of the CBC were normal, except that we found that the differential count of YAPCs, there was persistent peripheral eosinophilia. The normal eosinophil count is 0.4, but here it was 2.15, 2.2, 2.8, 2.2. Persistent absolute peripheral eosinophilia. It's normal 0.4 or 400, and here 2.15 or 2150, 2.2, 2.8, 2.2. And here we start to think. There's joint pain, muscle pain, and peripheral eosinophilia. And the differential diagnosis here start to reshape again. We found that CK total, creatine kinase total, was 167 unit per liter elevated, and the same for LDH 378, and there was severe deficiency of vitamin D less than 3 nanogram per ml. The immunological marker for lupus and rheumatoid were negative. The viral markers, hepatitis B, C, HIV were negative, and cytomegalo Epstein-Barr were all negative. We start to go to imaging. Echo, normal. Ultrasound, hepatosplenomegaly, mild hepatosplenomegaly, and electromyography showed evidence of myopathic affection more in the lower limb. Okay. The patient, we do a CT scan with contrast for this patient, and they show hepatomegaly 10 centimeters and subcentimetric lymph nodes with the cervical, axillary, and upper aortic region. And we will see the films now. As we see here, as we ascend through the abdomen, lower abdomen, intestine, paraspinal muscles, both kidneys, liver and gallbladder. There is hepatomegaly, normal spleen, para-aortic lymph nodes. As we continue, there is also axillary lymph nodes as we see here now, and there is cervical lymph nodes here. MRI sacroiliac joint was done, and the surprise here that the sacroiliac joints were both normal, but the other surprise here that we found in the muscles of the pelvis, symmetrical swelling with high T2 steer signal intensity seen involving the visualized part of paravertebral and gluteal muscles with intramuscular interstitial edema, leaving muscle lethargy appearance. We will see now the lethargy appearance and the interstitial edema of both paravertebral and gluteal muscle. Here, there is the gluteal interstitial edema, lethargy appearance. We will see again paravertebral muscles and edema, interstitial edema, and lethargy appearance of both glutei and paravertebral muscles. Okay, and here we found that imaging show edema, no arthritis, and there is peripheral eosinophilia in the CBC. And on further questioning of the patient for further history, we found that the patient had history of eating pork meat cooked in improper way in more than one occasion. So we decided to go and do a gluteal muscle biopsy for our patient and send it for histopathological examination. And here comes the big surprise. The histopathological examination showed skeletal muscles, cores of skeletal muscle showing scattered granulomata formed of epithelioid cells, multinucleated giant cells, some portion of the parasite like Trichinella spiralis, moderate eosinophilic infiltrate. As we see here in the right side of the slide, the image shows. For the first look, there is intense inflammatory infiltrate by small blue cells filling most of the slide. These small blue bilobed cells are eosinophils. These intense eosinophilic infiltrate to the slide. When you see here, there is muscle fiber, or are skeletal muscle fibers. Here, there is, in the center of the slide, there is a granuloma. Here, this is the granuloma. As you see inside the granuloma, there is a characteristic multinucleated giant cell here with characteristic horseshoe arrangement of nuclei. This is epithelioid cell. Here, this is a part of the parasite. Here is a part of the parasite. So, we conclude that this course of skeletal muscle showing intense inflammatory infiltrate by eosinophils, central granuloma with multinucleated giant cell epithelioid cell, and part of a parasite Trichinella spiralis parasite. So, our diagnosis is trichinellosis. Trichinellosis is a parasitic infestation. The man here act as an intermediate host. The definitive host, usually a rat or dog. The definitive host is who passes the eggs of the parasite in his feces. When the pork, which acts as another intermediate host, feed on these eggs, he will develop encysted larva in striated muscle. So, for the man to eat this meat, it must be cooked properly. If it is eaten improperly cooked, the patient will ingest the encysted larva. The larva will change into adult in the small intestine, as we see here, and the adult will deposit the larva in the mucosa that will invade the intestinal mucosa, reach systemic circulation, causing generalized manifestation and encysted larva in multiple organs, including the muscles. Site infection may be asymptomatic. Intestinal invasion phase may show gastrointestinal symptoms. The larval migration through the muscles cause periorbital edema, sometimes conjunctivitis, fever, myalgia, splinter hemorrhage, eosinophilia, and we found here in our patient. And sometimes there's occasional life-threatening infection causing manifestations like myocarditis, CNS infection, and pneumonitis. And larva encystment in the muscle cause myalgia and weakness. And there's a classic triad for trichinellosis, which is myalgia, periorbital edema, and peripheral eosinophilia, and all components of the triad were found in our patient. Okay. Laboratory diagnosis on clinical suspicion, you must do clinical suspicion plus eosinophilia, much do antibody detection by enzyme immunoassay, and the muscle biopsy and microscopy. Treatment, albendazole or mebendazole. They are a microtubule inhibitors that inhibit mitotic spindle formation, so causing death of the parasite. And we here saw the doses: 400 milligram for albendazole twice per day for 15 days. But the mebendazole 200 to 400 milligrams 3 times a day for 3 days, and 400 to 500 milligrams 3 times a day for 10 days. It is contraindicated for pregnant women and young children less than 2 years, and sometimes we use steroids in severe muscle affection and severe organ affection, including myocarditis and CNS affection. Returning to our patient, he received oral albendazole 4 mg twice a day for 3 weeks, and small dose of oral steroids 15 mg prednisone a day, and there was marked improvement of the patient in the 3rd week. The gait improved, muscle improved, flexion, deformity improved, and the patient later on regained his normal life. To end our case, we must say that wrong eating is the disease. Here, eating the undercooked pork meat was the disease. But right eating is the medicine. And thank you so much for your listening to our case. Hope that it was exciting, and I am ready now for any questions, and goodbye.
unmute يا حنان.
أي دكتورة دالي. أي دكتور أحمد، الحالة جميلة جدا من ناحية العرض ومن ناحية الورك أب والتريتمنت. ودلوقتي لو حد عايز يسأل حاجة يتفضل. اتفضلوا يا جماعة لو حد عايز يسأل حاجة.
هي الأسئلة بتبقى مكتوبة، هو للأسف دكتورة داليا عبد المحسن، حضرتك تحبي تسألي حاجة؟
لا أنا أحب أخلي الأسئلة لآخر السيشن، ممكن؟
تمام، أوكي.
طيب دلوقتي الحالة الثانية بتقدمها الدكتورة شيماء. اتفضلي يا دكتورة شيماء.
بسم الله الرحمن الرحيم. My name is May Morsi, Demonstrator of Rheumatology at Alexandria University. First, I want to thank my dear professor to give me such a chance. My case is a 44-year-old female patient presented to the ER complaining of grade 4 dyspnea 2 days before admission. She also complained of moderate amount of hemoptysis and reddish discoloration of her urine in the last month. Review of systems was otherwise free. The patient denied the presence of oral ulcers, hair fall, joint pain or swelling, skin rash, or neurological complaint at the time of examination. Her past medical history shows not diabetic, not hypertensive, but HCV positive. The patient started to complain of generalized body aches and joint pain 6 months previously. She sought medical advice and was diagnosed at that time to have hepatitis C infection. She received a prescription for analgesics for the pain and was advised to seek treatment for hepatitis C. Her routine investigation in the following month shows severe anemia. She received more than 6 packed RBCs units with no improvement in her hemoglobin level. And as such, she didn't receive any antiviral therapy. Her past surgical history free, drug history non-steroidal for her arthritis. Physical examination was vital signs, respiratory rate 35 and heart rate 95. Pallor, coarse crepitation bilaterally, otherwise free. Her preliminary investigations showed hemoglobin 6.5, creatinine 3.3. Urine analysis showed protein 2+, pus cells 5 to 7, RBCs more than 100 with dysmorphic RBCs, and granular karst. Ultrasound abdomen was done and showed bilateral average size kidney, good CMD, increased echogenicity with no masses, stones, or hydronephrosis. A remarkable echo Doppler study with ejection fraction 70%. CT chest was done and showed diffuse ground glass opacities bilateral. It was suggestive for intra-alveolar hemorrhage. Her serology showed HCV antibody positive, PCR showed high viremia, positive antinuclear with ELISA, positive B-ANCA by immunofluorescent. Otherwise, hepatitis B, HIV were negative, anti-double strand negative, C-ANCA, anti-GPM cryoglobulin, all were negative with normal level of C3 and C4, RF, latex, and rosewater, and CCP were also negative. Our differential diagnosis was either SLE, ANCA-associated vasculitis, Wood-Patcher syndrome, cryoglobulinemic vasculitis, or other diagnosis. Renal biopsy was done and showed diffuse mesangial hypercellularity with increased thickness and splitting of her glomerulobasement membrane, with moderate increase in the mesangial matrix. The picture suggestive of mesangiocapillary or membranoproliferative GN. By reviewing the causes of mesangiocapillary GN, it's either with cryoglobulins like hepatitis C or mixed cryoglobulinemia are related to HCV infection, or without cryoglobulin like shunt nephritis or other chronic infection including endocarditis, autoimmune diseases like SLE, Sjögren syndrome, viral infection like hepatitis B, hepatitis C, HIV, and parvo B19, and other causes. Immunofluorescent staining show heavy messenger granular IgM deposition with negative IgA immune staining, and granular mesangial and GBM IgG deposition. So it's not the full house picture of SLE, or not the pussy immune picture of NK-associated vasculitis or linear deposition like anti-GBM. Our preliminary diagnosis was HCV-associated mesangiocapillary glomerulonephritis. Now we have a 44-year-old female patient with intraalveolar hemorrhage and membranoproliferative GN with granular IgM deposition. HCV, antinuclear, and BNK were positive, RF cryoglobulin negative, C4 with a normal range. Vasculitis in HCV, it's either cryoglobinemic or non-cryoglobinemic. Non-cryoglobinemic, like HCV-related polyarteritis nodosa. Can our patient be classified as cryoglobinemic vasculitis? By reviewing the preliminary classification criteria for cryoglobinemic vasculitis, it's satisfied if at least 2 of the 3 items, questionnaire, clinical laboratory, are positive. The patient must be positive for serum cryoglobulin in at least 2 determinations at more than 12 weeks interval. It wasn't fulfilled in our patient. So, can HCV cause small vessel vasculitis in the absence of cryoglobulin? The answer was yes. By reviewing the literature, there was a case report of leukocytoclastic vasculitis associated with HCV infection, was published at the British Journal of Rheumatology 1997. The patient was 15 years old with leukocytoclastic vasculitis associated with hepatitis C infection. And the biopsy showed deposition of IgM and fibrinogen by immunofluorescent study. And the conclusion was it's possible that HCV can induce autoimmunity independent of cryoglobulins and liver involvement. Other article was published 2011 at the Journal of Rheumatology of Systemic Vasculitis in the patient with HCV infection with or without detectable mixed cryoglobulinemia. The conclusion was HCV-related systemic vasculitis may occur in the absence of detectable mixed cryoglobulinemia. The findings suggest that such vasculitis probably result from immune complex-mediated mechanism, and the therapeutic management of such a vasculitis should be similar to that of HCV mixed cryoglobulinemic vasculitis. So our final diagnosis was HCV-associated non-cryoglobulinic pulmonary renal syndrome. After hepatology consultation, hepatitis B core IgM was negative, so we started sofosbuvir, daclatasavir for HCV 12-week course, simultaneously with immune suppressive therapy. Immune suppressive therapy was 1 gram methylprednisolone for 3 consecutive days, followed by 15 milligram per kg, cyclophosphamide B monthly for 6 doses. Follow-up, on starting the steroid, was noted symptomatic improvement. Hemoglobin level stabilized, then greatly increased, and creatinine normalized. HCV PCR became negative at 1 month. We sustained response at 3-month follow-up. Patient is now on 5 milligram prednisolone and azathioprine with no relapse. Thank you.
شكرا يا دكتورة مي، ميرسي خالص. ودلوقتي نبقى مع الدكتور الحالة الثالثة إن شاء الله. اتفضلي يا دكتور.
السلام عليكم. أنا الدكتورة يمنى أحمد النهارده. السلام عليكم ورحمة الله. أنا الدكتورة يمنى أحمد، مدرس أمراض الباطنة روماتيزم ومناعة جامعة القاهرة. هقدم النهارده كيس presentation. A 22 years old female, mother of 4 years old kid with no special habits of medical importance. The condition started 2 months before admission. with additive bilateral symmetrical polyarthritis affecting large and small joints of acute onset and progressive course. The condition was associated with fever up to 39, improved partially with analgesic and antipyretic, and not associated with morning stiffness or joint deformity or back pain. Investigations were done and revealed pancytopenia, proteinuria 1 gram, ANA was positive, anti-double-stranded DNA was positive, and C3 and C4 were consumed. She was diagnosed as a case of systemic lupus and started steroid 1 gram per day for 3 days and was maintained on oral 40 milligram per day and mycophenolate mofetil 2 gram per day with improvement of the arthritis and blood picture but with persistence of fever. One month later, the patient developed ecchymotic tender reddish to purple skin eruption involving the face and the extensor surface of the elbow and knee joints. Dermatological consultation was done and provisionally diagnosed as a case of Sweet syndrome, acute febrile neutrophilic dermatosis, and they recommended to start colchicine until skin biopsy result is available. One week later, she presented to our ER with high-grade fever, progressive skin rash, where MRI brain with diffusion was done and screening for antiphospholipid antibodies was done. الMRI بين إن في bilateral cerebral cortical and subcortical white matter lesions and vasculitis should be considered. Large right occipital recent infarction for clinical correlation. أما الantiphospholipid profile كان negative. Three days later, the patient developed acute left-sided weakness and hypothesia, lower motor neuron facial palsy and motor aphasia with disturbed conscious level and referred back to our ICU. كان ساعتها الباثولوجيكال examination للسكين بايوبسي طلعت ان الحالة is erythema nodosum fibrosa. And thank you.
unmute yourself يا دكتورة حنان لو سمحتي.
انا عملت unmute خلاص.
طب حضرتك نقدم الحالة الآخر حالة؟
مش هما كده 3 حالات؟ وفي حالة رابعة؟
دكتورة فاطمة حامد.
اوكي. بس هي ما خلصتش الحالة بتهيألي ولا لسه في حالة هي كده خلصت؟
بسم الله الرحمن الرحيم. First of all, I'd like to express my honor to participate in the first EGYSIR virtual conference with this case presentation. Sometimes we find ourselves in front of cases with a lot of findings, a lot of I'm telling the story of a male patient aged 58 years, housewife from Al-Mahalla Al-Kubra, married with 2 sons, 2 daughters, and no special habits of medical importance. The patient complained from fatigue and decreased urine volume 2 weeks ago. Our patient was diabetic 8 years ago on oral anti-diabetic medications and shifted to insulin 1 week ago. Her blood glucose was not adequately controlled. There is no previous history suggestive of diabetic retinopathy or nephropathy. Her condition was in the form of oliguria 2 weeks ago, gradual onset, progressive course, darkening of urine color, dysuria, and line pain. Her condition was associated with fatigue, continuous low-grade fever, bone aches, pain and swelling in hands and dyspnea, and dry cough, and associated with swallowing difficulty. Upon examination, our patient appeared ill. She was of average build, no pallor or jaundice, but patient had peripheral cyanosis of fingers and toes. Patient was fully conscious, oriented to time, place, and person. Her vital signs show blood pressure was elevated, was 170/100. Pulse was 90 beats per minute. Respiratory rate was 22 per minute, and temperature was slightly elevated, was 38 degrees centigrade. Head and neck examination revealed thick skin, narrow oral aperture, vertical furrowing of perioral skin. Also, there was bilateral palpable axillary lymph nodes. It was single, about 1 centimeter in size, firm and not tender. Upon examination of the hand, as we can find in the photo, we have decreased skin elasticity of the fingers. We can find the swollen fingers, coldness and closed discoloration, bilateral and symmetrical, tender and swollen metacarbophalangeal joints with normal and equal pulse. Lower limb examination also showed decreased elasticity of the skin of the fingers, swollen fingers, coldness and closed discoloration with grade 1 edema. Chest, cardiac, abdominal, and neurological examination were all normal. Her investigation showing complete blood count was normal apart from anemia, normocytic pneumochromic anemia. Hemoglobin was 8 grams per deciliter. Blood film showing no histiocytes. It was unremarkable. Creatinine was high, it was 7 milligrams per deciliter. APG showing metabolic acidosis. Liver biochemistry was normal apart from low serum albumin, 2.3 grams per deciliter. Electrolytes showing sodium and potassium were normal, and corrected calcium was 9.1 milligrams per deciliter. Urinalysis showing proteinuria, RBCs, and pulse in the urine. 24-hour urinary protein was 770 milligrams per deciliter, very high. SCL 70 and virology all were negative. Abdominal ultrasonography was normal as rigor delivered the kidney, and there was no ascites. Chest X-ray also was normal, and fundus examination was normal. There was no diabetic retinopathy, and axillary lymph node ultrasound showed that it was reactive lymph nodes. High resolution CT chest was done to confirm or exclude interstitial lung disease, and we found that there was multiple enlarged bilateral lower deep cervical, axillary, and few mediastinal lymph nodes. The largest is 1.5 centimeter in diameter. There was also mild pericardial effusion, bilateral lower long loop cystic bronchiectasis, and there was bilateral basal areas of grounded glass opacity suggestive of interstitial lung disease, and this was the CT of the patient. As we can see, bilateral grounded glass opacity suggestive of interstitial lung disease was before the era of COVID-19, of course. So according to the ACR-EULAR criteria for diagnosis of systemic sclerosis, we can find that we consider that our patient having sclerodactyly distal to the MCP but proximal to the PIP. Also, we have interstitial lung disease, Raynaud's phenomena. So the total score is 9. So we can consider our patient as a case of systemic sclerosis. We think that we are in front of a case of active systemic sclerosis, and so a case of sclerodermal renal crisis. So we review the literature, and we find that as all we know that Systemic sclerosis is a complex and dynamic disorder which has inflammatory, autoimmune, tissue damage, and fibrosis, and it's very important to assess the biological stage of the disease to distinguish activity from severity and damage. And in active phase, the patient usually complain of diffuse soft tissue discomfort, itching, skin appear erythematous and with non-pitting edema. And the skin condition continues to worsen, typically over 12 to 18 months. During active skin phase, there is increased risk of internal organ involvement, and internal organ involvement may be silent or biologically active. Also, we can find during the active phase of systemic sclerosis, arthritis, or tenosynovitis. What about the acute kidney injury? What's your differential diagnosis? We think about scleroderma renal crisis, diabetic nephropathy, or something else. As regards scleroderma renal crisis, we think about it because our patient have active scleroderma, hypertension, oliguria, and normal fundus. However, there was no schistocytes in blood film, and blood pressure of the patient was easily controlled with calcium channel blockers. As regards diabetic nephropathy, we think about it because our patient was diabetic 8 years ago and having proteinuria and normal renal ultrasound. However, her fundus examination were normal, and also we have systemic features suggestive of systemic sclerosis, which cannot explain this condition. Or maybe something else. I think we need more evidence. So we do renal biopsy for the patient, and while we were waiting for the renal biopsy results, unfortunately, our patient developed progressive dyspnea, respiratory distress, hemoptysis, and here hemoglobin fall to 5 grams per deciliter. This was the CT of the patient showing infiltration mainly on the right side, suggestive of either pneumonia or alveolar hemorrhage. And finally, this was the results of the renal biopsy. We can see here the glomeruli showing fibrinoid necrosis, neutrophilic infiltration. Also, we can see the cellular crescent. Also, we can see the necrotic arteries. This was the comment of the renal biopsy. And the final diagnosis for the renal biopsy was necrotizing vasculitis with diffuse crescent. What do you think the relation between our case and this histopathology? Review the literature and you find that systemic sclerosis had the relation with vasculitis. Small, medium, and large vessel vasculitis have been reported with systemic sclerosis, and ANCA-associated vasculitis appear to present a unique subclass in that they combine typical features of systemic sclerosis with the renal manifestation of ANCA-associated glomerulonephritis. ANCA-associated vasculitis need to be considered as a differential diagnosis in systemic sclerosis patients presenting with renal insufficiency. So do you think our case is a case of systemic sclerosis combined with ANCA-associated necrotizing vasculitis? What about the strange lung infiltration? What about the patient age, which was old? What about the lymphadenopathy and the bone aches? I think we need more search for another diagnosis in our case. So for this reason, we did another battery of investigations. We did the ANCA, which was positive. Also, we did bone survey to search for hidden malignancy, and we find that our patient have few stylolytic bony lesions in the skull. For this, we did plasma protein electrophoresis, which showed monoclonal gammopathy. Also, bone marrow biopsy was. What do you think? Now we have a case of biopsy-proven ANCA-associated necrotizing vasculitis and features of systemic sclerosis and some features of multiple myeloma. I think the situation has become complex and tangled. We need to detangle this. How can we do this? We try to find a relationship between ANCA-associated vasculitis and multiple myeloma. We find that paraneoplastic vasculitis and multiple myeloma incidence is very low, and it's mainly present as leukocytoclastic cutaneous vasculitis. Also, we have one case record of double positive vasculitis for anti-GBM and ANCA vasculitis associated with multiple myeloma. We have another case report of association between ANCA-associated vasculitis and multiple myeloma, but all these are just case reports. What about the relationship between systemic sclerosis and multiple myeloma? This was a study that done for the prevalence of monoclonal gammopathy in rheumatic diseases. This study concluded that monoclonal gammopathy was observed in patients with a lot of rheumatic disease, like systemic sclerosis, rheumatoid arthritis, lupus, ankylosing spondylitis, and many other. However, systemic sclerosis was the most frequent type. The presence of monoclonal gammopathy may be associated with higher disease activity and also the development of hematological neoplasia, including multiple myeloma and lymphoma, was more in these settings. Also, this is a case report of systemic sclerosis and myositis as a paraneoplastic syndrome associated with multiple myeloma. We have also this study, which was done on the prevalence of monoclonal gammopathy and systemic sclerosis. And this concluded also that there is high prevalence of monoclonal gammopathy among patients with systemic sclerosis, especially in patients aged more than 50 years, as in our patients, and significantly associated with cancer. Also, this is a very interesting case report about the patient. This patient was also old age female, which was presented with thick skin, also with interstitial lung disease and arthralgia, and presentation very similar and mimicking systemic sclerosis. However, upon skin biopsy, it was confirmed that this is a case of scleroderma. And upon investigation, the patient was confirmed to have multiple myeloma, and so this was a presentation of a scleroderma mimic. So, do you think our case may be a case of a scleroderma mimic? Maybe. It may be amyloidosis, as amyloidosis is common with multiple myeloma, and it will present with Raynaud's phenomena, sclerodactyly, skin thickening, swallowing difficulty, carpal tunnel syndrome, and arthritis, and all these findings were present in our case. Also, scleroderma is one of the scleroderma mimic, which is present with multiple myeloma, as the case report in the previous slide, which will present with waxy, thick skin, mainly on the face, upper back, more than fingers, pulmonary hypertension, arthritis, and dysphagia. So I think our case need further evaluation with skin biopsy. However, this was not available in our case to confirm the diagnosis. And thank you.